Good morning, ladies and gentlemen. I'm Dr. Armen, Professor Astvatsatryan Armen. You are seeing Dr. Y. So you're on Dr. Y, and we continue to talk about. Today we'll start to talk about COPD. So what's chronic obstructive pulmonary disease? So chronic obstructive pulmonary disease, or COPD, is airflow limitation caused by an inflammatory response to inhaled toxins, often cigarette smoke. So actually COPD, COPD, let it be COPD. So COPD is a chronic obstructive pulmonary disease. Actually, on my point of view, is more correct COPD. But anyway, so COPD is an airflow limitation caused by an inflammatory response to inhaled toxins, often, very often, in 99% of cases, is a cigarette smoke. Alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency and various occupational exposures are less common cause in non-smokers. Symptoms are productive cough and dyspnea that develop over years. Common signs include decreased breath sounds, prolonged expiratory phase of respiration, and wheezing. Severe cases may be complicated by weight loss, pneumothorax, frequent acute decompensation episodes, right heart failure, and or acute chronic respiratory failure. Diagnosed is based on history, physical examination, chest X-ray, and pulmonary functional test. Treatment is with bronchodilators, corticosteroids, and when necessary, oxygen and antibiotics. Long volume reduction procedures or transplantation are used, now we see, in advanced disease. About half of patients with severe COPD die within 10 years of diagnosis. So COPD comprises chronic obstructive bronchitis, bronchitis clinically defined, emphysema, pathologically or radiologically defined. Okay, so bronchitis and emphysema. We understand that is one of parts of COPD. Many patients have features of both. Actually, difficult to say this is emphysema or just chronic obstructive bronchitis. Many patients have features of both. Chronic obstruction bronchitis is a chronic bronchitis with airflow. We'll talk about bronchitis with airflow obstruction. So chronic bronchitis is defined as a productive cough on most days of the week for at least 3 months total duration in 2 successive years. So we understand that we talk about cough. We talked about cough, right? Yeah. Chronic bronchitis become chronic obstructive bronchitis if spirometric evidence of airflow obstruction develops. So degrade chronic bronchitis becomes chronic obstructive bronchitis. If airflow obstruction develops on spirometry. Chronic asthmatic bronchitis is in a similar overlapping condition characterized by chronic productive cough, wheezing, and partially reversible airflow obstruction. It occurs predominantly in smokers with a history of what? Of asthma, my friend. Yeah, of asthma, of course, of asthma. In some cases, the distinction between chronic obstructive bronchitis and chronic asthmatic bronchitis is unclear and may be referred to as asthma COPD overlap, ACO. So emphysema is destruction of lung parenchyma leading to loss of elastic recoil and loss of alveolar septa and radial airway traction, which increases the tendency for airway collapse. Lung hyperventilation, airflow limitation, and air trapping follow. Airspace is enlarged and may eventually develop bleps or bullae. Obliteration of a small airways is thought to be the earliest lesion that precedes the development of emphysema. Epidemiology of COPD. So in the US, about 24 million people have airflow limitation, or whom about 16 million have a diagnosis of COPD. COPD is the third leading cause of death, resulting in more than 140,000 deaths each year, compared with 52,193 deaths in 1980. From 1980 to 2000, the COPD mortality rate increased 64% and has remained steady since then. Prevalence, incidence and mortality rates increase with age. Prevalence is higher in women, but total mortality is similar in both sexes. COPD, thanks for sexes, not for transgender, my colleagues. For gender, not transgender. Thanks for sexes, not gender. COPD seems to aggregate in familiars independent of alpha-1 antitrypsin deficiency, alpha-1 antiprotease inhibitor deficiency. COPD is increasing worldwide, not only in the United States, because of the increase in smoking in developing countries. The reduction in mortality due to infectious disease and the widespread use of biomass fuels such as wood, grasses, or other organic materials. COPD mortality may also affect developing nations more than developed nations. Of course. COPD affects 64 million people and caused 3.2 million deaths worldwide in 2015, and is prolonged to become the third leading cause of deaths globally by the year 2030. About etiology of COPD. There are two main causes of COPD: smoking and less often other inhalational exposures. Inhalational exposures and genetic factors, of course. But inhalational exposure is the most important, of course. Of all inhalational exposures, cigarette smoking is the primary risk factor in most countries. Although only about 15% of smokers develop clinically apparent COPD, an exposure history of 40 or more PEG years is especially predictive. Smoke for indoor cooking and heating is an important causative factor in developing countries. Smokers with pre-existing airway reactivity defined by increased sensitivity to inhaled methacholine, even in the absence of clinical asthma, are at greater risk of developing COPD than are those without. Low body weight, childhood respiratory disorders, and exposure to passive cigarette smoke, air pollution, and occupational dust, for example, mineral dust, cotton dust, or inhaled chemicals, for example, cadmium, contribute to the risk of COPD, but are of minor importance compared, of course, obviously, with cigarette smoking. So about genetic factors, the best defined causative genetic disorder is alpha-1 antitrypsin deficiency, which is an important cause of emphysema in non-smokers and markedly increased susceptibility to disease in smokers. More than 30 genetic alleles, okay? More than 30 genetic alleles have been found to be associated with COPD or decline in lung function in selected populations, but none has been shown to be as consequential as alpha-1 antitrypsin. Pathophysiology of COPD. Various factors cause the airflow limitation and other complications of COPD. Inflammation. Inhalational exposures can trigger an inflammatory response in airways and alveoli that leads to disease in genetically susceptible people. The process is thought to be mediated by increase in protease activity and decrease in antiprotease activity. Lung proteases such as neutrophil elastase, matrix metalloproteinase, and cathepsins break down elastin and connective tissue in the normal process of tissue repair. Their activity is normally balanced by antiprotease such as alpha-1 antitrypsin airway epithelium-derived secretory leukoproteinase inhibitor, LFN, and matrix metalloproteinase tissue inhibitor. In patients with COPD, activated neutrophils and other inflammatory cells release proteases as a part of the inflammatory process. Protease activity exceeds antiprotease activity, and tissue destruction and mucus hypersecretion result. Neutrophil and macrophage activation also leads to accumulation of free radicals, superoxide anions, and hydrogen peroxide, which inhibit antiproteases and cause bronchoconstriction, mucosal edema, and mucous hypersecretion. Neutrophil-induced oxidative damage, release of profibrotic neuropeptides, for example bombesin, and reduced levels of vascular endothelial growth factor may contribute to apoptotic destruction of lung parenchyma. The inflammation in COPD increases as disease severity increases, and in severe advanced disease, inflammation doesn't resolve completely despite smoking cessation. The chronic inflammation doesn't seem to respond corticosteroids. Infection. Respiratory infection which COPD patients are prone to, may amplify progression of lung destruction. Bacteria, especially Haemophilus influenzae, colonize the lower airways of about 30 patients of COPD. In more severely affected patients, for example those with previous hospitalizations, colonization with Pseudomonas aeruginosa or other gram-negative bacteria is common. Smoking and airflow obstruction may lead to impaired mucus clearance in lower airways, which predisposes to infection. Repeated bouts of infection increases the inflammatory burden that hastens disease progression. There is no evidence, however, that long-term use of antibiotics slows the progression of COPD. No evidence, and they will not, I'm sure. Airflow limitation. The cardinal pathophysiological feature of COPD is airflow limitation caused by airway narrowing and/or obstruction, loss of elastic recoil, or both. Airway narrowing and obstruction are caused by inflammation-mediated mucus hypersecretion, mucus plugging, mucosal edema, bronchospasm, peribronchial fibrosis, and remodeling of small airways, or a combination of these mechanisms. Alveolar septa and destroyed. Alveolar septa are destroyed. Alveolar septa are destroyed, reducing parenchymal attachments to the airways and thereby facilitating airway closure during expiration. Enlarged alveolar spaces sometimes consolidate into bullae, defined as airspace more than 1 centimeter in diameter. Bullae may be entirely empty or have strands of lung tissue transversing them in areas of locally severe emphysema. They occasionally occupy the entire hemithorax. These changes lead to loss of elastic recoil and lung hyperinflation. Increased airway resistance increases the work of breathing. Lung hyperinflation, although it decreases airway resistance, also increases the work of breathing. Increased work of breathing may lead to alveolar hypoventilation with hypoxia and hypercapnia, although hypoxia and hypercarbia can also be caused by ventilation perfusion mismatch VQ ratio. Of course, complications, VQ ratio, ventilation perfusion. In addition to airflow limitations and sometimes respiratory insufficiency, complications include pulmonary hypertension, respiratory infection, weight loss, and other comorbidities. Chronic hypoxemia increases pulmonary vascular tone, which, if diffuse, causes pulmonary hypertension and cor pulmonale. The increase in pulmonary vascular pressure may be augmented by the destruction of the pulmonary capillary bed due to destruction of alveolar septa. Viral or bacterial respiratory infections are common among patients with COPD and cause a large percentage of acute exacerbations. It's currently thought that acute bacterial infections are due to acquisition of new strains of bacteria rather than overgrowth of chronic colonizing bacteria. Well, it's questionable, but anyway, weight loss may occur perhaps in response to decreased caloric intake and increased levels of circulating tumor necrosis factor, TNF-alpha. About calories, actually, I don't know, but anyway. Other coexisting or complicating disorders that adversely affect quality of life and or survival include osteoporosis, depression, anxiety, coronary artery disease, my friends. Coronary artery disease, lung cancer and other cancers, muscle atrophy, and gastroesophageal reflux. The extent to which these disorders are consequences of COPD, smoking, and the accompanying systemic inflammation isn't clear. About symptoms, COPD takes years to develop and progress. Most patients have smoked more than 20 cigarettes a day for more than 20 years. So 20. Productive cough usually is the initial symptom. Cough is initial symptom. Productive cough usually is the initial symptom, developing among smokers in their 40s and 50s. So the better stop smoking before this age, of course. Dyspnea, that is progressive persistent exertion or worse during respiratory infection, appears when patients are at their late 50s or 60s. Symptoms usually progress quickly in patients who continue to smoke and in those who have a higher lifetime tobacco exposure. Morning headache develops in more advanced disease and signals nocturnal hypercapnia or hypoxemia. Morning headache. So, signal of hypercapnia or hypoxemia, sign of hypercapnia or hypoxemia. Signs of COPD include wheezing, a prolonged expiratory phase of breathing, lung hyperinflation manifested as decreased heart and lung sounds, and decreased anteroposterior diameter of the thorax, barrel chest. Patients with advanced emphysema lose weight and experience muscle wasting that has been attributed to immobility, hypoxia, or release of systemic inflammatory mediators such as TNF-alpha. Signs of advanced disease include pursed lip breathing, like this, accessory respiratory muscle use, paradoxical inward movement of the lower rib cage during inspiration, Hoover sign, and cyanosis. Signs of cor pulmonale include neck vein distension, splitting of the second heart sound with an accentuated pulmonic component, tricuspid insufficiency murmur, and peripheral edema. Right ventricle heaves are uncommon. Right ventricle heaves, are uncommon in COPD because the lungs are hyperinflated. Spontaneous pneumothorax may occur, possibly related to rupture of bullae, and should be suspected in any patients with COPD whose pulmonary status abruptly worsens. The symptoms can be graded according to which activity caused dyspnea. Okay, let's talk about this actually. Why not? So, breathlessness measurement. Breathlessness measurement using the Modified British Medical Research Council questionnaire, MRC questionnaire. So grade 0, shortness of breath, none except during strenuous exercise. Very resembling, like New York Heart Association classification concerning chronic heart failure, or Canadian classification of angina. Very resembling. So grade 1, occurring when hurrying on level ground or walking up a slight incline. Shortness of breath appear. Grade 2, shortness of breath resulting in walking more slowly than people of the same age on the level ground, or resulting in stopping for breath when walking at own pace on level ground. Grade 3, resulting in stopping for breath after walking about 100 meters or after a few minutes on a level ground. Grade 4, last one, so severe enough to prevent the person from leaving the house or occurring when dressing or undressing. Actually, acute exacerbations may occur sporadically during the course of COPD and are heralded by increased symptom severity. The specific cause of any exacerbation is almost always impossible to determine, but exacerbations are often attributed to viral upper respiratory infections, acute bacterial bronchitis, or exposure to respiratory irritants. As COPD progresses, acute exacerbations tend to become more frequent, averaging about 1 to 3 episodes a year. Okay, my friends, that's enough for first part of COPD. Yes, of course, it will be continued. Don't forget to make your donations, please. How to make your donations you can find in description of this video in YouTube or in podcast. And if you are looking me watching this show, watching these lectures in YouTube, follow and subscribe and put the ring on to be in touch with all news from Dr. Y. Thanks you very much. Thanks in advance. Thanks for everything and for donations, of course. It will be highly appreciated. See you in another lecture. It will be very interesting. God bless you.